Namaste to all of you. I, Javier Nagma, the lecturer of the discipline optometry in the Department of Physiotherapy. Today I am here to present the topic of dry eye. What is a dry eye? Dry is a common eye condition that occurs when your tears aren't able to provide adequate lubrication from the eyes. Tears can be inadequate for many reasons. For example, dryness may occur if you don't produce enough tear or if you produce a poor quality tears. The definition of the dry eye is a multifactorial disease of the tears and the ocular surface that result in symptoms of the discomfort, visual disturbance, and a tear film instability with a potential damage to the ocular surface. It is accompanied by the increased osmolarity of the tear film and the inflammation of the ocular surface. The tear film image, you can see there is the eye and the meibomian gland. This is form of the lipid layer. The lacrimal gland that is formed produce the aqueous, and the goblet cell that is produce the mucus layer. The tear film has a three layers: lipid layer, aqueous layer, and the mucus layer. The tear film. Introduction of the dry eyes. Dry eyes are recognized as a disturbance of the lacrimal function unit and the integrated system compromise the lacrimal gland. Ocular surface, the cornea, conjunctiva, and the meibomian gland and lids are the sensory motor nerves that connect them. The functional unit controls the major component of the tear film and the response to the environmental, endocrinological, and cortical influence. Its overall functions is to preserve the integrity of the tear film, transparency of the cornea, quality of the image projected onto the retina. The trigeminal sensory fibers arising from the ocular surface run to the superior salivary nucleus in the pons. Efferent fibers pass a nervous intermediate pituitopallidine ganglions. Here, the posterganglionic fibers arise which terminate in the lacrimal gland, nasopharynx, and the vessels of the orbit. The dry eye, also known for the keratoconjunctivitis, xerophthalmia, xerosis, and the Jorgen syndrome. The mechanism of the dry eye is the inflammation of the conjunctiva and the accessory glands is in 80% of the patient with the keratoconjunctivitis and may be a consequences of a dry eye. The hyper osmolarity of a tear is also a key mechanism of a disease and may be the major pathway of the epithelial cell damage. The classification of the dry eye is aqueous layer deficiency and evaporative. The aqueous layer in a two forms, a Jorgen syndrome and non-Jorgen syndrome. The evaporative is a meibomian gland disease, exposure defective blink, in contact lens associated environmental factors. The Jorgen syndrome, it is a systemic autoimmune condition characterized by the lymphocytic infiltration of the exocrine glands and the mucous membrane, resulting in the secondary secretion, leading to the abnormalities in the tear film and the ocular surface. The primary features are the keratoconjunctivitis and dry eye with a dry mouth. Diagnostic criteria. The diagnostic criteria is the symptomatic criteria. Ocular symptoms or use of artificial symptoms. Oral symptoms of the xerostomia. Swollen salivary glands or a frequent need to drink. The objective evidence of the keratoconjunctivitis, positive involvement of the minor salivary gland or the labial biopsy. The salivary involvement of the demonstrated by the psilography and the scintigraphy. Laboratory evolution for the extractable nuclear antigen, anti-nuclear antibody to or rheumatoid factors. Causes of a non-Jorgen keratoconjunctivitis. The primary age-related hypersecretion, that is lacrimal tissue destruction, tumors and inflammation, absence and reduction of a lacrimal gland tissue, surgical and real congenital scarring with obstruction of a lacrimal gland tissues, ducts, chemical burns, cicatrizing pemphites, Stephen Johnson syndrome, and old trauma. The neurological lesions with the sensory and motor reflex loss, Parkinson disease, and the reduces the sensory may also contribute to a dry eye after refractive surgeries and the contact lens. Vitamin A deficiency. Causes of evaporative meibomian gland dysfunction, positive blepharitis, atopic conjunctivitis, congenital meibomian gland dysfunction. The lagophthalmos is a severe proptosis, facial nerve palsy, eyelid scarring following blepharoplasty. Miscellaneous contact lens wear, the environmental factors such as air conditioner. Symptoms worsen during the day, dryness, grittiness, burning, sting, discharge, transient blurring of the vision, redness, crusting of lead. The sign, the posterior blepharitis due to the meibomian gland dysfunction, that is a conjunctiva, may show a mild keratinization and redness. Tear film due to a meibomian gland dysfunction. Punctate epithelial erosion due to a dryness of a cornea. The complication is a very severe cases include a peripheral superficial corneal neovascularization, epithelial breakdown, and bacterial keratitis. The investigation shows the stability of a tear film, tear breakup time, tear production, thermus fluorescent fluorescence, and the tear osmolarity, ocular surface disease, corneal stain, and impression cytology. The tear film breakup time. The tear film TBUT is abnormal in aqueous tear deficiency and the meibomian gland disorder, measured as follows: fluorescent in a 2% or and the impregnated fluorescent strip. Moisture with a non-preserved saline is still into the lower pharynx. Patient is asked to blink several times. Tear film is examined with a broad beam and the cobalt blue filter. After an integral of the time, black spot or a lines appear in the fluorescent stain film, indicating the formation of a dry eyes. The TBUT is an interval between the last blink and the appearance of the first randomly distributed dry spot, and the birth of the less than a 10-second is abnormal. The Shermer's test, Shermer's test for testing to the quantity done with a strip of the filter paper measuring the 5 to 35 mm. The type 1 done by the patch placing the strip on a lower fornix as the junction of the outer 1 by third and the inner 2 by third of 5 minutes. More than the 15 mm of the wetting in a 5 minute. Normal Watchman filter paper 41 now a standard and gives the values for a basic and reflex secretion of a tear. Basal secretion conjunctival is anesthetized before the performing test. Type 2. To know the basal secretion of the tears done by the stimulating anesthetized nasal mucosa by the cotton tip and note the wetting after 2 minutes. This is the silent use of the normal wetting is a 15 mm. Greater than a 5 mm indicates a severe keratoconjunctivitis. Type 3 Sherman's test to know the reflex secretion and ask the patient to look directly to in a sun no diagnostic values and the potential dangers. Modification of a thermos test by the John multiplied the distancing of a wetting of the standing strip. Placed for a 1 mm by the factors of a 3 and found it to correlate with the 5-minute reading. A modified thermos test in which the standard strip intended to the place for a 5 minute also moved to a different place if there was no waiting after first or 2 minutes has been reported to obviate false positive result. The other test is the fluorescent clearance test. Standardized for amount of a fluorescent, 3 microliter of a 0.5% fluorescent is a placed in a conjunctival sac, and the tear turnover rate is determined by the persistence of a fluorescent in the tear at a specific time points later. To detect amount of a residual fluorescent, we use a Sherman's strip to collect a fluorescent stained tears. Fluorophometer quantify amount of a fluorescent persisting in eye minimally is stimulated tear samples collected using a microtube from the inferior tear meniscus. After 20 minutes, fluorescent is the measured and the converted into a fluorescent concentration of the matched with a standard fluorescent uptake. The normal value is a 22.4 plus minus 16.9. As it grade 1 is a 96.4, grade 2 is a 318, and grade 3 is a 1479. The management is a goal therapy, relief to a discomfort, provide a smooth optical surface, prevent a structural damage cornea. General measures: avoid being a dry atmosphere for a long period of a time, avoid a direct blast of the heaters and air conditioner at the face level, sit away from the direct heat such as a furnace, fires, gas, etc. Use a lubricating eye drop such as artificial tear. Make a consequences effort to blink regularly with a full lid closer and not a half blink. Avoid smoking. Use a wraps around the glasses and sunglasses when outdoors. Maintain the lid hygiene. Systemic therapy, medical management, and surgical management. Tear substitute artificial tears, and the ointments are the carboxymethyl cellulose, sodium 1% drop, the hydroxyl cellulose 0.44%. Punctate occlusion reduce drainage and preserve natural tears and the prolong the effect of the natural tear. Greatest values in a patient with a moderate to severe keratoconjunctivitis, SICA, who have not respond to a frequent use of a topical treatment. The contact lens. Long-term contact lens pain may increase the tear film evaporation, reduce the tear flow, and increase the risk of the infection. This effect can be outweighed by the reservoir effect of a fluid trapped behind the lens. Scleral contact lenses provide a reservoir of a saline over the cornea. They can be worn on the extremely dry eye with exposure. Other option, tarsography. Tarsography is a diminished surface evaporation by reducing the palpebral aperture. Botulinum toxin injection to the orbicularis muscles may help control the blepharospasm in a severe dry eye. Inject into medial canthus, it reduces a tear drainage and pre-assembly by blocking lid movements. Thank you. Have a nice day.